Okay, good afternoon, everybody. My name is Arjun Taka. I'm one of the hepatobiliary surgeons at Southampton University Hospitals, and welcome to the webinar by the Royal College of Surgeons, Edinburgh, which is about the management of surgical jaundice. Just very quickly, I'd like to thank the Royal College of Surgeons, Edinburgh, for the opportunity to run this series of webinars. I've done a couple before, which are excellent, and hopefully you'll have much the same experience with this one. I'm a Royal College of Surgeons Regional Surgical Advisor, and our speaker, Mr. Mike Silver, is the lead sort of RSA for the Royal College of Surgeons Edinburgh, and Michael is a fellow hepatobiliary consultant at Oxford University Hospitals, along with being the lead for the Regional Surgical Advisor Network. Michael also has an interest in training and is in fact the training program director for the general surgical trainees for the Oxford Deanery, but also plays a very prominent role in academics in HPB surgery and is on the board of a number of distinguished journals. Very quickly, we would be very keen on you guys using the Q&A session so you can ask questions, which we will try and answer straight away. Or if we get a question that's asked a number of times, I will then save that question up to ask the speaker at the end. We'd be also very grateful if you could use the thumbs up button to flag questions, which then can move up the priority chain. And of course, at the end, we will remind you of the next webinar, which is in 2 days' time, which is on the management of fractures. So without further ado, I'll ask Mr. Silver to start the presentation.
Thanks for that introduction, Arjun. Folks, welcome to this webinar. I hope you find it useful. Both Arjun and I are hepatobiliary surgeons, and most, or if not many of our patients present to us with jaundice that needs surgical interventions or treatment. But not all jaundice patients need surgeons, and it is important for you to try and understand which of the patients you see who present with jaundice actually need to have the attention of a surgeon, or which needs to be sent across to our gastroenterology colleagues or hepatologists, for example, or who may even get better without any intervention at all. A little concept you need to understand, we know that there is a normal level for serum bilirubin. It could be either in micromoles or milligrams per deciliter, depending on which scale you use. If one was to develop jaundice, for it to become clinically obvious and actually for you to see jaundice in the patient, it needs to reach a level of greater than about 40 millimoles. In fact, it's around 50 that you start seeing that the patients become jaundice. And this is something that you need to bear in mind. The metabolism of bilirubin, we all know that it usually is a breakdown of hemoglobin to biliverdin, which is insoluble, and then it gets conjugated in the liver and eventually makes its way into the bile duct. Now, surgeons like myself will get involved if there is a problem with drainage of bile and there is an obstruction to the ducts themselves. An obstructive jaundice characteristically has a yellow discoloration, but incidentally also has pale stools and dark urine in the presentation. And that's when you need to realize that you probably need to think about obstructive jaundice rather than a prehepatic or a hepatic cause for the jaundice. Looking at the causes for jaundice, you can think about obstructive jaundice caused by a problem within the lumen of the bile ducts, and gallstones feature very highly in this. You could also see parasites like liver flukes. It's increasingly becoming common in the West due to the fact that people travel a lot, and also food stuff, especially fresh food, reaches the UK, for example, within 24 hours from much afar, and therefore can cause problems. Intramural, as in within the wall, a problem where you can get thickening of the wall. This could be congenital. like in biliary atresia, or you could have a benign stricture caused by conditions like sclerosing cholangitis or IgG4 disease and malignant strictures. Extraluminal, meaning outside the wall, you could have benign or malignant causes. And in these, we consider pancreatic cancer and periampullary tumors as the common ones. So the ones highlighted here as causes are what we essentially like you to think about when you see a patient. And broadly speaking, are you looking at a benign cause like gallstones, or are you looking at a malignant cause like pancreatic cancer or a periampullary lesion or a stricture? When presented with a patient with jaundice, there's a spectrum of jaundice, and sometimes you might see, like in the picture on the left-hand side, where you see a little tinge of yellow discoloration, and you're not really sure as to whether this is jaundice or whether it's just a muddy sclera, as some people might have. And jaundice usually appears in the outer upper quadrant of the sclera when it's very mild, or you can have a barn door presentation where you recognize this even before the patient walks into and sits down in your consultation room. And with that, you need to be looking at other associated symptoms like itching, abdominal pain, weight loss, or fatigue, along with the dark stools and pale urine. But the important thing, the message I'd like you to latch on to, is that if you see a patient with deep jaundice, pale stools and dark urine, and associated no pain associated with that, that is a patient you need to suspect malignancy in. And that's an important consideration that you must take away from this. The patient's age is important because you can associate age with presentation of malignancy. For example, someone in their late 60s with jaundice, malignancy would feature highly as compared to someone in their 20s or 30s who has a very short history as compared to a history that's long and insidious over a few weeks or months. So the duration of symptoms and the age of the patient is something that you need to consider while taking a history. The presence and absence of pain, like I emphasized on the previous slide, is important because pain is usually associated with gallstones and signifies a benign presentation rather than a jaundice that has no associated pain, which I will say again and again is probably due to a malignancy. The cause of the jaundice is also important, and by that I mean, is the jaundice something that came on progressively? Is it sudden onset over a few days, or has it been gradually increasing over a few weeks? And has it been intermittent? You could have intermittent jaundice for various presentations, and you can have fluctuating jaundice where the jaundice never leaves, but it can get bad and then become less severe over time. And also look for other symptoms like fever, anorexia, weight loss, which could signify a more sinister cause. But don't forget, if there is no pain, the cause could be a malignancy. Just a few words about intermittent jaundice. You need to know that you can have jaundice that comes and goes, and this is usually associated with stones that can pass, so you can get a stone popping into the bile duct, and the pressure within the system pushes the stone out and the jaundice clears. You can get similar sort of presentation with ampullary cancer, where the ampullary tumor sometimes can slough off, and that can then result in the jaundice clearing, and then the tumor regrows into the sloughed off area and causes jaundice again. Other conditions like choledochal cysts or IPNBs, intraductal papillary neoplasms of the bile duct, can also cause intermittent jaundice. So something to consider when you hear that history. When you're examining the patient, look for signs of jaundice. Look at the sclera, look at the skin, look for the yellow discoloration and the associated scratch marks. You will see patients while talking to you scratching themselves simply because it's so itchy and unbearable. And sometimes that's their most overriding presentation and symptom because it keeps them awake at night. So remember to look for that and make note of that. Look for signs of cancer, especially weight loss. And some patients don't bother to weigh themselves, so wouldn't know whether they've lost weight if they're not really observant. Ill-fitting clothes is a giveaway sometimes, and that is something to make note in your history. And then in those patients, you'd look for signs like supraclavicular nodes, umbilical nodes, or if you do a rectal examination, can you have feel for other deposits? And you come across this law that's referred to often, especially in exams, and that's Courvoisier's law. Especially if you look at this picture, you can see a patient who has a presentation that's suggestive of malignancy and has, in this case, a visible and palpable gallbladder, especially if it's painless. Just to explain what Courvoisier's law really is, Courvoisier was a Swiss surgeon who described this sign all those years ago, and the theory behind it is that if you have gallstones, you end up with recurrent attacks of cholecystitis, and therefore the gallbladder becomes shrunken and thickened due to chronic inflammation, and therefore will not expand even if there is pressure within the system. So if you get a stone at the bottom of the bile duct, the pressure within that wouldn't cause the gallbladder to expand, and you wouldn't feel it when you examine it. And that's what is meant by Courvoisier's law. A palpable, non-tender gallbladder in the presence of jaundice is unlikely to be due to gallstones. So the key there is non-tender and unlikely. So a tumor here can cause back pressure and a palpable gallbladder. Nothing in law in medicine is definite, and nothing is if you ever hear something as being mentioned as always, that usually is incorrect, especially in an MCQ. So look for exceptions, and you can get exceptions where in the first presentation of gallstones, a stone pops down and obstructs the bottom of the bile duct while also obstructing the cystic duct, causing a palpable gallbladder. A word about fever and cholangitis is associated with gallstones. So a stone in the common bile duct can sometimes cause infection within the biliary system, and that can present as a very sick patient with fever, jaundice, and also abdominal pain, and that has been given the designation of Charcot's triad, described by this French neurologist all those years ago. Investigations, your aim really is based on whether this patient has jaundice or not in the first place. So confirm your jaundice and then assess the patient for symptoms that could have been caused by the jaundice itself. So hydration, liver and renal function, and hematological changes can all result as a secondary to the jaundice. Especially if a patient has jaundice, dehydration can result in hepatorenal dysfunction. So you need to make sure that the patient's renal functions are okay. Also, the patient could have associated sepsis, and that's why you would want to do a full blood count. And the jaundice itself can impact the clotting mechanism, so a clotting profile is important. You also need to diagnose the cause of jaundice, and that is something else that has to be considered when you are planning your investigations. Don't forget, jaundice is not a diagnosis. It's like saying a patient's got a temperature. You need to find the cause for that, and that's a part of why you do your investigations. So your liver function tests will tell you that you've got your jaundice, and unlike years ago when we used depend on urine analysis to confirm if the jaundice is present or not. We go straight in to look for an elevated bilirubin, especially if there is obstructive jaundice. You'll find that the conjugated component is much higher than the unconjugated. And an alkaline phosphatase, usually around 3 times the normal, is associated with a complete obstruction. But the key investigation result that confirms jaundice in this case is your elevated bilirubin. We'd like to take a poll here, because once you've confirmed the diagnosis, the next is a few imaging tests that you'd want to do, and what would you consider as being the first line investigation in a patient you suspect to have jaundice. Is it a plain X-ray abdomen, a CT scan of the abdomen, an ultrasound scan, or an MRI scan? Let's see how you vote. And excellent. That's the answer I would expect. And the ultrasound scan is the best first line investigation in this presentation. And moving on, what question would you be asking your sonographer when you ask for an ultrasound scan? And the answer to that question is very simple. Have you got dilated bile ducts in the scan? Can you see biliary dilatation? That signifies that there's an obstruction to the flow of bile, as you can see very well in this. And remember, an ultrasound scan has excellent sensitivity to picking this presentation of dilated bile ducts. And this is where you decide or confirm that this patient actually has obstructive jaundice. If you don't see dilated ducts, the cause for the jaundice is very likely to be an intrahepatic cholestasis or a prehepatic cause, and therefore consider a hepatitis screen and referral to a hepatologist and further investigations along those lines. But for us as surgeons, what we would want to do is to take the patient forward and manage the patient's obstructive jaundice once it's diagnosed. So what do you do once you've got your ultrasound scan results? If you've got a dilated gallbladder or a gallbladder full of gallstones and dilated bile ducts, and in that scan you can see stones within the common bile duct, the patient needs to have an ERCP to have the ducts cleared, and then a cholecystectomy. So that's the treatment pathway that the patient will go on. But more often than not, you'll see that this patient will have gallstones in the gallbladder, the common bile ducts dilated, but you cannot see the bottom of the bile duct because of obscured view due to the transverse colon, and therefore you're not sure as to whether the patient has a stone at the bottom of the bile duct. That patient should not go straight to ERCP for reasons we will discuss in a little bit. The patient should have an MRCP to confirm as to whether there is a stone in the bile duct before proceeding to ERCP, which is the safer route. And if you have no stones in the bile duct, in the gallbladder, and dilated ducts, then in that case, you would want the patient to have a CT scan to give you a better idea as to what the cause for the dilatation is. Just a few words about a CT scan. CT scans provide excellent information in addition to what an ultrasound can provide. And a CT scan sometimes might be the first imaging modality that you might choose, especially if in your history and examination you suspect cancer. It has better resolution. It has excellent evaluation of liver and pancreas and the other organs. It provides good views of the bile duct. It can define the anatomy better. And if you suspect malignancy, it's excellent for staging the disease as well, and it might help you with your diagnosis with biopsies. It has some disadvantages, and those are that it requires a huge exposure to radiation, which has a cumulative effect. So especially in young patients, we try to avoid scans, CT scans if possible. And also you need to give IV iodine-containing contrast that can sometimes cause an allergic reaction. It could rarely cause some renal dysfunction, but that's not a consideration that's considered important any longer, and it does cost a lot more than an ultrasound scan to do. Just to go through a CT scan here, you can see in cross section that the ducts are dilated here, and coming down you can see that you can trace the common bile duct down to what looks like a tumor at the bottom of the bile duct near the head of the pancreas. In the same patient, looking at coronal views, you can see a very dilated, elongated gallbladder, and in the next image you can see that the patient has a dilated common bile duct and also a dilated pancreatic duct with a tumor in the head of the pancreas. So you get a very good idea of what the cause is, and also you're able to stage the disease with a CT scan. Now, in certain instances, we would use an MRI scan, and not always, because a CT scan is much better for staging the disease in this instance. An MRI scan is more useful if you want to look for subtle lesions in the liver itself, or in patients where a CT scan is unsafe or cannot be used due to the reasons we discussed earlier. It does not use any ionizing radiation, and therefore it's very safe to use, especially repeatedly. But it has disadvantages, and one of them is that if the patient's claustrophobic, you wouldn't want to stick them in a CT scan where they are surrounded by a very noisy, confined environment while the scan happens. And also because it uses very strong magnetic fields, you can have problems with implants that the patient may have. But it does give imaging that has a lot of features that will tell you that, like seen here at the bottom of the bile duct, you've got a stone. You have a feature in MRI scans that's called MRCP, where you have subtraction of all the other tissue while the common bile duct and the pancreatic duct is highlighted very clearly, and that is an MRI sequence that takes much less time than an MRI scan itself, and therefore costs less and utilized much more often than is a MRI on its own. So an MRCP is a quicker, cheaper, and easier test to do, and therefore used quite often. So the considerations once you've confirmed jaundice is you need to establish the cause for the jaundice and also manage the consequence of the jaundice itself. You need to be looking at itching caused by the jaundice, the liver dysfunction causing derangement of clotting, and the risk of hepatorenal dysfunction must be mitigated along with pain management if the patient is in pain. Jaundice causes a lot of itching due to the bile salts being impregnated in the tissues, and the use of emollients and counter irritants like crotometone cream can help, but it usually does not take away the symptoms completely, as is the use of chlorpheniramine, which is Piriton, that can sometimes help with the itching. Now, cholestyramine, which can sometimes sequestrate the bile salts in the bowel, is useful in jaundice that is not obstructive and has no place in the use in obstructive jaundice. Vitamin K is given to correct clotting, and this is usually IV 5 or 10 milligrams And then you need to make sure the patient's well hydrated. So IV access and IV fluids and electrolyte replacement is very important. If needed, you need to catheterize the patient and make sure that you've got a good fluid balance before you proceed to any other investigations or management. The next consideration is how you overcome the jaundice itself. Now, this could be temporary while you plan a definitive treatment, or it could be a definitive management if, for example, it's a stone obstructing and therefore you need to clear the duct of the stone. If it's a cancer you're suspecting, you need to stage the disease, and we've discussed how you stage the disease initially with an MDT plan. In suspected choledocholithiasis, once it's confirmed, you need to clear the bile duct. And this is usually done with an ERCP, where you enter the lower end of the bile duct with a scope that has a side viewing endoscope, and you cannulate the duct, and with a Domia basket, you can extract the stone as is depicted in these sequence of pictures. In your cross-sectional imaging, as we saw in the scans previously, if you see a dilated bile duct along with a dilated pancreatic duct, and that's a sign that we recognize as double duct dilatation, you see a dilated bile duct and dilated pancreatic duct in the presence of ampullary or lower bile duct cancer. And that is a sign that you should always know is a significant finding that suggests malignancy. And this is another depiction of that, where you have a very dilated bile duct here, and in this pancreatic duct dilatation at the bottom of which you see a tumor. And that's the same patient with a dilated bile duct and the pancreatic duct with a tumor at the bottom. And that's a cartoon depicting what was just discussed, where you have a tumor causing the bile duct and the pancreatic duct to be dilated. And in that case, what you would do is, with your ERCP, place a stent across the block so that you overcome the dilatation. And at the same time, with the ERCP, you can put in a brush, which is like a flue brush, which is entered into the stricture region, and you can move it up and down so that you can gather cells that can be looked at by a pathologist to make a diagnosis. So that is one of the initial managements of your jaundice patient. Remember that ERCP can cause pancreatitis, bleeding, and perforation. So those are considerations when you put a patient through that. And sometimes you can fail to cannulate, or you can fail to clear the duct. And in which case, what you're left with is a patient with jaundice that needs to be cleared by entering through a transabdominal route. So if you look at this picture, you can see that you can enter the liver with a needle, and while withdrawing it, you inject some contrast so that you can see the contrast within the bile duct, and then you cannulate the bile duct in such a way that you can enter the duodenum percutaneously so that you can drain the patient percutaneously. So you can drain it externally, and then internally, once you establish control internally, and place a stent and get brush cytology just like you would do for ERCP. So to summarize, if you have a patient with jaundice, you need to ascertain in your history whether you are dealing with either a benign or malignant condition. You need to also be aware that painless jaundice can depict a malignant cause, and if you establish that there is surgical jaundice in a history and examination, proceed to an ultrasound scan. The question you're asking is, are the ducts dilated? You need to manage the effects of jaundice by dealing with the itching, hydration, and clotting derangements, overcome the jaundice by clearing the duct, or a temporary or permanent stent. And once you've got the cause, if it's a cancer, you need to stage and treat it, and remember to treat the cause. Thank you.
Okay, that was fantastic, Mike. Thank you very much for a very comprehensive rundown of the jaundice patient. A couple of questions have popped up, and I'm just going to run through a couple of them because they, they have shown up a number of times. So one is, one got asked a few times, which was, when would you perform an MRCP over an ERCP? I think you briefly touched on this. Could you just go through that for us again, if you would?
Yes, I think that's really important. So an ERCP is used if you suspect a stone in the bile duct and you want to clear the stone, and that's the usual common presentation. Sometimes you might need an ERCP to, like I showed in my slides, to get a brushing from a stricture, and place a stent. But if you've got a patient with jaundice and you see stones in the gallbladder, having a dilated duct does not necessarily mean that there is a stone at the bottom of the bile duct. And you wouldn't want to do an ERCP straight away without actually confirming that there is a stone at the bottom of the bile duct. So the usual sequence is diagnose obstructive jaundice, confirm it with an ultrasound scan. If you don't actually see a stone in the bottom of the bile duct, you proceed to do an MRCP, confirm that there actually is a stone at the bottom of the bile duct, then proceed to an ERCP, rather than going to an ERCP straight away because there might not be a stone, or that stone may have passed and you do an ERCP unnecessarily and expose the patient to the risks of ERCP, which are perforation and pancreatitis, pancreatitis being the more common one. Does that answer the question?
One more question, Mike, very quickly. Can you discuss the uses of cholestyramine and ursodeoxycholic acid, and whether this is something we use commonly in our surgical practice?
So cholestyramine has no place, like I mentioned, in the management of obstructive jaundice until and unless you have cleared the blockage and the bile is reaching the bowel. If and when you've got a stent in place and the patient's still jaundice and the jaundice is clearing, the cholestyramine will prevent the reabsorption of the bile into the bloodstream. And that then is a useful adjunct to your management of jaundice. Or you can use cholestyramine in patients who are jaundice not due to obstruction. So to say it
so
again,
there was a mention, someone mentioned that these drugs are used in conditions such as PSC and similar sort of autoimmune hepatitis conditions. So what's the difference there as opposed to what we do it for in a surgical practice?
Yes, so in PSC, the obstruction, if the patient's jaundice, is usually intrahepatic cholestasis, and there is still a degree of flow of bile into the bowel. And in autoimmune hepatitis, the problem is usually intrahepatic rather than obstructive. Again, there is flow of bile into the bowel. And in both those conditions, usage of cholestyramine will chelate the bile in the bowel and prevent reabsorption, therefore reducing the amount of bile actually reaching the bloodstream from the bowel, and therefore helps with reduction of the jaundice.
There's a couple of questions on the role of PTC in jaundice.
So that was the penultimate slides, and PTC has a place if you have a problem with the hilum of the bile ducts. That's the confluence where the left and right join, and if there's an obstruction there, and you cannot overcome that obstruction using ERCP and stenting. So if your ERCP has failed for some reason, or if you cannot cannulate, then you would go transabdominally using a percutaneous drain and a PTC. PTC is not the first line simply because it's more invasive and the risks of bleeding and complications are greater than with ERCP. And it is less, it's used less often than would be ERCP. So usually the tendency is to try and decompress the ducts with ERCP, and if that fails, then you would try PTC.
Okay, excellent. Mike, there's one last question which I think is relevant to practice. Could you comment a little bit on the role of endoscopic ultrasound in the management of obstructive jaundice?
So endoscopic ultrasound has a role in the management of obstructive jaundice, especially if you are trying to get a diagnosis and you have failed with your ERCP and brushings. Endoscopic ultrasound does not have a big role to play in obstructive jaundice in the therapeutics of it, as in the management of the jaundice per se or reduction of the blockage. Endoscopic ultrasound is helpful for you to take an image-guided biopsy of a lesion that is not accessible with a transabdominal biopsy route. So for example, if there is a tumor at the bottom of the bile duct or in the hilum of the liver that you cannot actually access with a transabdominal needle, then endoscopic ultrasound is a useful adjunct to directing your biopsies.
Apologies, I was muted there. Thank you very much, Mike. We'll leave it at that. There were excellent questions. I think we tried to get through most of them. And that was a really informative, excellent presentation. This is just to remind you that the next webinar is on the 14th, again at 4 p.m. UK time. And this is on the principles of the management of fractures. And we would hope that you would join us again then. Thank you.
Thank you, Arjun.